audience. So thank you for gathering. So I just want to take a moment to honor Dr. Tagi Modarressi, who was a psychiatrist, infant, child, adolescent, and adult psychiatrist and psychoanalyst here at the university, and really a leader across this region, Baltimore and DC. We have some folks here from our newly invigorated Infant Mental Health Association of Maryland and DC, and Dr. Modarressi and Carol Norris Schroeder were the people that started that for our region. And we're really proud to also not only do the work we do at the center, but also have that community-facing thing to celebrate with you all. You can learn more about it. He joined the faculty here in 1964. And he worked closely with the then dean to create this Center for Infant Study. And we really pretty much do what was started then, which is training. It actually started with a symposium with Eric Erickson and some other luminaries in the field at that time. And we do training. We do a lot of workforce development training, as well as our wonderful fellows and interns and externs, and also community work. So bringing infant mental health interventions, preventions, and treatments into places where families show up every day. And then we also have our wonderful clinic. So I think Dr. Modarressi really understood the value of interdisciplinary workforce. And I think probably nowhere better than infant mental health to really be a shining example of what that looks like. And it really is all of us working together, trained around the same core values of relationships matter, and really understanding that honoring what families and communities do are adaptations to whatever they're going through, and really putting that at the core of understanding how the child's development is unfolding. So I'm going to pass it to Dr. Sarah Edwards, our division director, to introduce our guest professor lecturer this year.
Good afternoon, and thank you so much for joining. It is truly my pleasure to introduce Dr. Maria Music, who's a professor of psychiatry and obstetrics and gynecology at the University of Michigan. She holds a medical degree from University of Vienna, Austria. I was like, not Australia, although that would be very cool too. And completed her residency in psychiatry, both at the University Hospital there and at Michigan. She also holds a master's degree from the University of Michigan School of Public Health. She's the medical director of perinatal and reproductive psychiatry at Michigan Medicine and of the MC3 perinatal program, which is a statewide perinatal psychiatry access program for primary care. At Michigan, she co-directs Zero to Thrive, a program which supports families who are challenged by adversity to help them thrive across pregnancy to postpartum. She co-developed Strong Roots, which is a menu of resiliency-oriented interventions. Her research work focuses on the impact of adversity and mental illness in the context of childbearing on caregiving and the developing parent-child relationship. On a personal note, I had the pleasure of meeting Maria back, and I looked it up. It was November of 2017. And since that time, we have partnered together on many projects. And we're really excited that we are able to, she'll be talking about her Mom Power group, that we have done that since that time. And we have served over 180 women. So we're really excited about this partnership and collaboration. And with that, please welcome Dr. Music.
Thank you so much.
Welcome.
Awesome.
No, just want to make sure it works.
Excellent. Hello, everyone. Oops. I'm a little bit shorter than everyone else. It's one of the features that I remembered by. So it's a pleasure. It's an honor to be here, back here. I've been here a couple of years ago in 2018, and I'm back here, and it's always wonderful to be here. It's fine. I can use that. I think it's working out well. So my topic is healing across generations, promoting infant mental health perspectives in the context of perinatal care. You heard I'm a perinatal psychiatrist, but with kind of this broader lens of psychodynamic and infant mental health background. And I want to kind of run through setting the stage in the beginning. I don't know your backgrounds. If everybody is like buying into our worldview of infant mental health, and if you're even like, what the heck is infant mental health? So I want to kind of give you a quick intro to why I think this is so relevant. And I want to start with, if this works, I don't know. Maybe it doesn't. It's okay. I can do it otherwise. So kind of saying why taking an infant mental health and early relational health perspective in perinatal care. And I think the answer is easy because perinatal period is by evolutionary design, multi-generational and relational. What do I mean by that? Well, there's actually a lot of research already, decades that we know that mammalians, and we are part of the mammalian species, that we are hardwired and for parenting and for caregiving and for the parent-child bond, and that it's exquisitely orchestrated across, sensory, behavioral, hormonal, and brain structural areas that are similar from rodents to primates to humans, just get a little bit more complicated. So we are hardwired for these connections, and we have brain areas that are designed for the parent-infant bond. You might know this research, and this is relatively new data, but has been coming online for a while. And I see some nodding in the audience. Well, the parental brain undergoes massive changes across this perinatal period in preparation of caregiving, from pre-pregnancy, pregnancy to post-pregnancy, postpartum. And you ask yourself, why would that be? Why is this so important to get ready? Well, because it matters. Caregiving shapes development and health of the next generation. You might know this data that actually, a lot of the synaptic and neuronal growth, yes, it happens in utero, but it really gets going postpartum in those first 2 years postpartum, and it's experience dependent. There's a lot of growth and then a lot of pruning. And so when you look, for instance, at cognitive development, when you look here, yeah, certain areas, this doesn't work at all, this thing. But if you look at certain things like seeing and hearing, that happens from day one of birth. So a lot of the function is already established. That's the first dotted line. But when you look at higher cognitive function, it's really dependent on that early years, first year up to 2 years out of experience to get these functions going. And not only cognitive functions, but also emotional development is highly dependent on the relational. Start on the bottom where it says responsive, affectionate caregiving. So if the parent is doing cognitive, like a responsive caregiving through oxytocin-related mechanism, it creates in the baby also the experience of attachment patterns. I will talk about this a little bit later, how interaction creates security or the lack of secure or insecure attachment. But these secure attachments are, of course, carried forward across the child's life and now promote, when you are on the right side of the schema,
not only healthy child development, healthy adult development, but now sets the child, who is now the parent, the adult, sets this parent to have high oxytocin receptor density and oxytocin. And now the parent can respond to their own infant distress signs or difficult behaviors with more empathy and attunement. And now they can create this responsive parenting that you see on the bottom. So it's a cycle, it's a circle that keeps on going. And that's why it's so important, this early period. So we always say the first 1,000 days from conception to early childhood are critical. I'm sure that you have heard about that. And it's not that it's deterministic. It's not that it, as Shankov said so nicely here, it's not because this period in development provides an indelible blueprint. It's not deterministic, but it is a springboard. It sets either a sturdy or a fragile stage from where development goes. How do parents do this, that they help this growth, both cognitive as well as emotional? You all, I'm sure, have heard about this term serve and return. It's a term coined by the Center for Developing Child at Harvard University. What they talk about is relational reciprocity that helps brain development. So it's like a tennis game or pickleball, which is like the new thing now, right? One serves and gives a cue, and then the partner has to respond and return the serve. And then it goes back and forth. And it's this modified back and forth that creates this experience. So let's, as an example, the child serves by reaching out for interaction, let's say with eye contact, facial expression, emotional expression, gesture, babbling, touch. And the parent returns the serve by speaking back, playing peekaboo, sharing a toy, laughing, mirroring, modifying the emotional, co-regulating. That is back and forth, is the day-to-day experience. And it is this day-to-day experience of interaction which then gets wired in our brain as a cognitive affective template. It's most likely amygdala, hippocampal, what we call the maternal or parental brain neurocircuit, that gets stored as a template for relationships, what it was like to be in a relationship, and who am I in this relationship. That's what we call attachment, right? It's this memory template, affective, cognitive, of what was it like with this person, with this figure, and who was I in this relationship? Was I valued? Was I loved? Was I safe? Was I nurtured? Or was it scary? And this is, as you know, not only saved in the brain, as in, we call it sometimes working memory of the relationship or affective template, it's also stored in our body as through sympathetic, parasympathetic nervous system wires. That's what Bessel van der Kolk talks about. The body keeps the score. That's what we are, where we store these memories. And the good news, as Donald Winnicott said, good enough is good enough. What is good enough parenting? It means let's get it at least 50% right of that emotional attunement. Everything 50 plus is good. It doesn't have to be 100%. That's wonderful. That's good news, because no, we are not 100%. And it would be even perfect attunement wouldn't even be promoting growth. So good enough is good enough. And yet good enough might be too hard for some families who are experiencing trauma, stress, and adversity. So let's talk about that a little bit. Parents face many adversities. There's a word cloud of some of the parents in our groups that speak about all kinds of adversity. And there are many, many, many more, you know, from mental health, hopelessness, to, you know, trauma, to racism, systemic racism, oppression, all these terms that are not allowed anymore, but I still will tell them. I hope they're still allowed here. Okay, good. Because they're real. this is what families are experiencing, and then access to healthcare, all these things that are impacting mental health. And as you might, know, I'm sure this is just a recoiling of for you that, the adverse childhood experiences are so have been linked to both adult mental as well as physical health, but they are rooted in adverse community environments. They're more likely that vulnerability for childhood adverse experiences are in the context of these adverse community environments, and in turn, these adverse community environments are rooted in something that is coined atrocious cultural experiences. My friend and colleague Chandra Ghosh Ibn has written about this in the Handbook of Infant Mental Health, that there are historical contexts that make these environments more harsh. And these are genocide, slavery, colonization, forced family separation, sanctioned attacks on individuals' bodies, removal of property and land, denial of basic human rights. So it's a cascade towards adversity. That's what our families are dealing with. My own work, this was my career development award many years ago. I looked at mothers who were exposed to childhood adversity and looked at their mental health. And as you can see, this is looking at comorbidity of depression and PTSD across the first 18 months postpartum. And you see that some moms on the left side, they're pretty resilient. They are always under the clinical threshold. Some moms are hovering over at the clinical threshold. But then there's a group of moms, and it was around 12%, who are always above the clinical threshold. And who are these moms? Logically, these are the ones with most abuse in their history, ongoing abuse, as well as high levels of shame, internalized shame, which is so co-occurring with trauma. I looked at how does this shape parenting from the same study. Published with my then postdoc, Cecilia Martinez Tortella, looking at, so if you have now this child abuse and then you have mental health problems, how does this impact your parenting? And it does. The good news is there was no direct connection from abuse to parenting. So abuse is not destiny. It's the mental health problem in between that was mediating this link. And it was ongoing adversity and stress. That's good news because we can do something about this. So it did shape responsive parenting. More psychopathology was linked with less behavioral and affective sensitivity or warmth and engagement. That was kind of the latent variable, responsive parenting. And in day-to-day interaction, so we looked at free play and teaching tasks and day-to-day interaction. And then we looked, how does this impact the infants coping in stress situations? You might be familiar with the still face procedure, where you stress socially the infant and the mom. And as expected, infants who experience day-to-day less responsive parenting in day-to-day interactions, when they then get stressed, they have a harder time coping with it. They have a harder time affectively recovering from the stress, and they are more flooded by cortisol. So we're already setting up some vulnerability here. And then what does this do to attachment? Well, if the baby experienced at age 6 months more intrusive, controlling, rejecting, hostile parenting, they were more likely to be insecurely attached. So there is an unfolding early on, just kind of to showcase what I said with data. Well, yet we have also buffering effects, like reflective parenting, and I want to highlight that because that is something that we call reflective capacity or parenting insightfulness, which is linked in the literature to responsive parenting, to child attachment security, and that is something we can modify. That's what we do in therapy. And in my own work, when you look at what's the correlation between responsive parenting and more stress in postpartum and adversity, you can see clear line. The more on the right side you had postpartum adversity and stress, the lower was your responsive parenting. There's a clear line going down, but that was only true for the moms with low reflective capacity. If they had high reflective capacity, you see it's mitigated. It's a straight line. So that's something we can work on. With that, I come to that point that what is reflective capacity? Well, it is establishing that between a stimulus, which could be my baby's crying, my baby's misbehaving, I have a reaction that's quick and unreflected, that I interspace a reflective functioning, a space, a reflective space where the parent can process, calm, and make an intentional, regulated, and potentially modifiable response. It's not reactive, but responsive. And that is responsive parenting. So if we think about intervention targets, kind of going back, we now talked about, well, there is adversity in childhood, there's postpartum adversity, there is that it shapes parenting, it shapes psychopathology, there's reflective capacity, and all of this will impact infant and child development and set the stage for this time period. So if we intervene, classic psychiatry, perinatal psychiatry, zooms in on psychopathology, right? And SSRIs, that's the answer. It's not. Therapy deals with trauma and kind of, unprocessing and social skills, skills-based intervention to help with current adversity, with coping. Dyadic therapy, parenting support is supporting with parenting. The point is, we need to do all of it. Perinatal psychiatry, because it's, going back to slide 1, a priori, a relational and multi-generational. We need at least 2 generation, if not multi-generational, multimodal, multi-target approaches. And that's what I call perinatal infant mental health. So speaking of infant mental health, you all know infant mental health. Anybody who has never heard this term before? I assume not, because you guys are here the center of infant mental health. But I want to introduce to you Selma Freiberg, if you don't know her. She's a Detroit native. She was at the University of Michigan at our Department of Psychiatry faculty as a psychoanalyst. Doesn't exist anymore. She was a social worker. Now it's only MD-centric and PhDs. No social workers are faculty anymore. That's one of my critique points. But back then, she was the professor, she was a director of this University of Michigan Child Development Project, 1965 to 79. Selma then, in 79, moved to San Francisco together with her student, postdoc at that time, Alicia Lieberman. And unfortunately, Selma, in 1980, passed from a brain tumor, but Alicia kept the spirit and actually advanced it. And I'm sure you all know that Professor Lieberman developed the kind of older age infant mental health add-on or expansion called child-parent psychotherapy. So I would like to play for you a 30-second clip. If you have never heard Selma talk, I think it's beautiful to have an access to her. This is a very old clip that we got hands-on from the 1970s.
In the Department of Psychiatry at the University of Michigan, the youngest patients have just been born. Infant patients at the Child Development Project cannot talk, but they can describe their problems in eloquent terms. A team of baby specialists in psychiatry, psychology, social work, and education provide a consultation and guidance program for parents on behalf of infants under 2 years of age. Mental health programs for babies maybe mental health insurance for the future.
I love that. Mental health for the infant is the insurance for the future. She was 1970s, she said that. At that time where people were like, what the heck is infant mental health? Do infants even understand? Do they even remember what's happening? Selma kind of laid her program as a home visitation program. And kind of spoke about this very eloquently, and I want to kind of read this because I think this is exactly the spirit of infant mental health, is that by observing and listening, staying open to both the pleasures and the pains, the home visitor joins the infant and the parent in creating a space where they can come together for one another. It is the safe space that the home visitor and parent together can observe, wonder about, explore, and understand the attachment relationship between the parent and infant. In the safety of the therapeutic relationship, parents may have and experience thoughts and feelings about the baby, the complexity of parenthood, as well as immediate hopes, worries, and concerns. They also may share stories about themselves that affect their ability to care for the very young children, experiences of the past, the present, abandonment, loss, separation, trauma, abuse, and neglect. That's the spirit of infant mental health. And that's basically the essence, is that's this unique field of there is always parent, infant, and the relationship as one complex for the intervention target. It was developed as psychoanalysis at the kitchen table. The approach is multifaceted, needs-driven, relationship-focused, and you explore the past, the ghosts, and the angels as they impact the here and now. Another schematic of infant mental health that people often show is like a house, right? And speaks to the fact that it's multifaceted and needs-driven, and that really at the basis of the foundation of this intervention is being culturally responsive and relationship-focused and creating safety and building alliance. And only then can I attend to the material needs, because that's often the first thing that I need to lead with, and giving emotional support and developmental guidance. And only if that is established, the foundation and the walls, can I move to dynamic psychotherapy. Another piece that is very important that she spoke about is reflective supervision, which is the roof, holding it all together. What is reflective supervision? Well, if you do this type of work, you need to understand that it also has an impact on you, how you are holding the parent-child dyad. And there is this saying by Jerry Paul, who was a co-worker of Alicia Lieberman and also of Selma, saying, do unto others as you would have others do unto others. What does that mean? As a mom, I can only give warmth and love and nurture to my baby if I have experienced it, if I know what that is. If I have not, who is going to give it to me? So the therapist needs to hold the mom so that she can hold mom and can hold the baby. And similarly, the therapist can only provide that holding ground if the supervisor is there to hold the therapist and the mom and the baby and the relationship. And the supervisor can only be there if the chair and the whole community is rallying and creating a space of safety and nurture. We can only do this work if we are creating these holding circles of circles of holding for each other, of safety and nurture. So my group is called Zero to Thrive, from ground zero, whatever that is for each individual person, to thriving. And that's what we aspire to. That's how we operate, our ways of being, that we developed, how we want to be with each other and with our patients and with our supervisors. And really the goal is to support family strength and co-create solutions with the families to the multi-generational effects of inequity, trauma, adversity from pregnancy through early childhood. And we do this, I want to give you a couple examples. How do we developed, or we have developed a cadre of programs to offer this perinatal infant mental health in varied settings to meet the parents where they are. Because that's also, you cannot, project the one program that you have to where you think it's convenient to you, but where the parents are, and have different modules and modalities for the parents where they are and are willing to or able to accept it in that moment and at the length that they are able to attend. So I want to give you examples from primary care, from community, and from the home environment. So I'm going to start with primary care. We do early relational screening and video feedback intervention. I assume you are familiar what video feedback is, where you then make a movie if the parent allows it of the relational interaction, and then play it back and discuss it with the parent. And this is happening in pediatric offices, family medicine offices, where the parent, when the physician might discover, or the parent might disclose, I'm struggling, that can suggest, do you want an extra session, kind of a fall with your baby in love session, or we call it try with your baby moments. It's an extra visit where then the clinician that you see, the person on the left side here is sitting on the floor with the parents. They talk, they take an intake, and then they shoot a movie with permission of the parent while they are interacting, and then playing it back. And I will talk about that a little bit more, how this can be done in any encounter. I want to give you some examples from the home. One is the infant mental health home visiting, which we are doing and we are evaluating, and then one from a statewide perinatal access program where I'm the director. So just kind of the power of home visiting with a relational focus. If you look on the x-axis, you have maternal either anxiety, generalized anxiety, or PTSD, as it relates to relational health, which is codified by mutual attunement and certain kind of codifiable variables in interaction. And we looked at baseline, so pre-intervention anxiety or PTSD, predicting to relational health. And what you can see is that here, a lot of anxiety or a lot of PTSD, your relational health is down. It's an inverse correlation. But that's only for those who were in the control condition. Again, for those who were in the treatment condition, it's flattened out the line. It's mitigated by the intervention. That is powerful. Let me talk about our perinatal access program. I know you have one here as well. Perinatal access programs usually have the component where, there are not enough perinatal psychiatrists out there, or pediatrics. There are also pediatric access programs. There are not enough psychiatrists out there. So we ask the primary care providers to do the work, support mental health, and we consult with you over the phone. So we do this as well. But in addition, what I've created is a direct access to short-term counseling for the moms directly. They can either be referred by the physician through during the visit, or there are flyers, and with the QR code, they can self-refer. The bottom line is that within the same day, when the mom says, I need help, I feel I need something, she needs to be able to connect to someone, right? And that's where she connects with the smartphone. Most people have smartphones, or if they don't, they can call in. But most people connect through smartphone and then say, how do I want to connect with the counselor? Via texting, email, phone, video chat. Most people start with texting and calling and then graduate to, more intensive like video chat. And what we do within a week, this counselor from the home, the mom is at her home virtually, does screening for risk and needs, brief counseling, 4 to 6 sessions. Again, relational health screen and relational health support, case management, care coordination with the OB, and then monitoring symptoms over the first year of life. All free of charge, currently funded by Medicaid in the state of Michigan. We'll see where it goes, but we'll keep fighting for it. So that's the idea. It's a collaborative care model. You can see that the way how this works is that in the middle is the mom and the baby, and she works with this perinatal infant mental health consultant. They do the work, and if the consultant has feedback for the OB, they do care coordination. And if the perinatal consultant weekly meets with the psychiatrist for panel review, that's collaborative care. What is the need? If there are medication needs, either the psychiatrist gives the information to the OB via the consultant or directly to but the bottom line is we wrap around this woman and help her psychiatrically and psychotherapeutically. And you can see when we monitor, we looked and so number one is baseline, and then each month you have it here 4 months out, how the scores drop. On the top is depression, on the bottom is bonding impairment. As the depression goes down, bonding impairment goes down. So that's good news. Okay, let me talk about community. We have developed this strong roots mental health and parenting intervention. And you see there are variants. It's something for moms only that's on the top called Mom Power. The name is always co-designed with the group that it's for. So the moms called it Mom Power. We have also a Spanish version now, Mama Empoderada. We are just translated to Arabic because in Detroit there is a lot of Arab speaking women. We have a version for dads. They didn't like Dad Power. They called it Fraternity of Fathers. We have one Strong Beginnings for families in child welfare. We have one for the whole family, one specific population, military families. The Strong Roots Peri-DBT is more for psychiatrically impacted moms with self-harm and suicidality, a lot of mood instability, who need a little bit more the DBT component. And Parent Cafe is more a peer-to-peer model in the community. So different variants, and we are working constantly on new variants. We are just working on a Mom Power for parents with kids on the autism spectrum, because that's a group that's the parents are so struggling and need that community and connection. And similarly, and you will hear more about that, parents who struggle with substance use disorder diagnosis. So all these Strong Roots projects or programs are group-based, are co-created by the parent and the provider. So they are co-designed. They're named by the group that they are for, by them. There's always a continued quality improvement aspect. It's always kind of a living framework, because wherever you go, when we have Mom Power in Hawaii with the native population, they need a different set than the women in Detroit. So it's really important that they co-create it. It's always a 12-week program led by a licensed therapist. We use nature metaphors, so we'll get to that why. And that aligns with the protective factors, which is a evidence-based framework. So Mom Power, evidence-based. We have a curriculum for the mom, and the moms bring the children between 0 and 6 to the group, so that it's also an embedded childcare, but it's beyond childcare. There's a child curriculum to also support the child and to support their relationship. We are evidence-based and in the California Clearing House registry, as well as the American Psychological Association registry. It's multi-generational. There's one session where the moms bring also their parenting partners, whether that's partner or grandma or whoever the person is, to kind of get them onboarded as well. 12 weeks, 13 session. I already said that. It's top down and bottom up. Top down means it's evidence-based and based on theory. I believe in science, I confess. We believe in attachment theory, relationship-focused theory, diversity-informed practice, trauma-informed care. All the coping strategy interventions like the T's, CBT, IPT, DBT, motivational interviewing. But we use nature metaphors. Why? Because nature metaphors speak to us, people. We have, it's co-designed with the families, and they complex concepts like attachment theory, which I will say in the next slide, you can break it down and talk about it in nature metaphor, and it's just much more easy. It's no psychobabble. It's language that is understandable and speaks to us because it is evocative of memories. We are connected with the universe and a part of this universe. Our native people, they know it. We are just the youngest siblings of the bigger nature, and trees have so much to tell us, to learn. The goal is to enhance reflective capacity. So you all know attachment theory, Bowlby's theory, where he talked about that there's this two innate motivational systems, exploration, where we are hardwired to learn and grow and thrive. Well, it's like branches of a tree that are thriving and growing. But that growing can only happen in times of safety and connection, and where you're grounded in safety. These two systems are opposing. The attachment or connection system, when that's active, when in times of distress and anxiety, you cannot learn. I don't know how the kids in Ukraine being bombed are learning in the cellars. So learning the connect mode is when you feel safe and secure. So Bowlby called it, parents give secure base and safe haven. And there is, how do parents do that? Well, they do it on the connect side by nurturing, restoring emotional balance, repairing disruptions of relationships. That's how parents do it. And secure base, how do parents support exploration? By enjoying, attending, and helping, facilitating, scaffolding. That's what parents do. Some parents are, I have a easier time doing one or the other, depending on their own attachment style. And that's kind of thinking this through, developing a vocabulary and talking through this, what part of mom power is. We use the Strengthening Families Protective Factors framework, which is evidence-based. We just kind of use different wordings because it's so intellectual, right? I mean, what parent says, oh, I have knowledge of parenting and child development, or I know the social emotional competence of children and communication. So bringing it down to user-friendly wording, and that's how Mom Power runs. The pillars are, it's an attachment-based parenting psychoed with, at the same time, supported parent-child interactions in the we call it sunshine time. A lot of self-care, because the moms have to experience themselves to be regulated, to be able to co-regulate, but then enhancing social support and connection to community resources. The intervention is, as I said, 13 sessions. It's bookmarked by individual sessions and one individual session in between to personalize it, but otherwise it's 10 group sessions. And then there is a lot of phone check-ins in between for needs. We have done research. That's where you see all the reductions of psychopathology, enhancing parenting capacity, empathy, reducing stress, enhancing availability, emotional, reducing social isolation, improving child outcomes. Specifically interesting is we did RCT in the community, and that did pre-post imaging of those who underwent the intervention and those who were in the control group. And what this task in the scanner was to probe for this empathy circuit. And the empathy circuit is, if I show you pictures of your own child with positive affect, can you attune to the positivity? Because that's so important. Being clicking with your child's positivity, that is so important for wellness and for relationship. So you see that the moms who go through Mom Power in this joint task for joy with the own child are increased after the intervention, whereas the controls are not. And the most important, what you see is that the more this activation happens, the lower the post intervention parenting stress. So could it be that the more empathy you have, the less stressed you are by your child misbehavior or whatever they show? Or is it because you are less stressed, you can have more empathy? I cannot say which one, but they are going together. And this is so important because that is protective. We all get stressed when our kids are stressed, but can I have times where I really enjoy my child? That's going to reduce my stress. That's going to create the relationship. So I want to feature our wonderful collaboration here. For a decade, we have been working with Mom Power. There's an active collaboration here with the University of Maryland, with this amazing team on Mom Power for mothers with OUD. They started initially, they came to training in 2017, and then we started here in 2018, and initially a pilot funding, and then, kind of outpatient clinic, and really hard to kind of get, but you got it through, and you got through the pandemic, and now with the state opioid response grants, bring this intervention to 120 women across 6 programs. And it really is moms who are getting that experience over 3 months to have that. And I just met, I'm so honored, Sylvia, right? Yes, bravo for doing this. Bravo. This is a tough group to work with, but they so in need, and it's predominantly African American women across different, urban, suburban, and rural parts. And I just want to, lead with some testimonials, because that's what it's all about. You can have the data and the numbers, but actually it's the testimonials to say, like a mom saying, the group gave me an understanding on how to deal with my 2-year-old. I can better deal with his anger and attitude and emotions. It gives me a clearer outlook on how to deal with him, how to take him on, because he would get mad. I would get mad, and then we both are mad, right? That's the reactive. Now we are all in this reactive. But she says, so being in the group has helped me calm down, take a minute, assess the situation, and go about it the way it is supposed to be done. That's reflective stance. That's reflection in action. Not a mom saying, I still always doubt myself about the things that I know, or if I'm good enough, or whatever. And then being able to talk with the ladies here, it gives me reassurance that I do kind of know, and I'm kind of good at most of it, and I understand most of it. It's just taking a second to realize the way you are doing things and how your child acts better. So that's probably why my baby is great. Self-confidence. Do you remember when I talked about that internalized shame and putting yourself down? That's what the women have, and that's so destructive. They need a sounding board where they can say, I'm actually doing it okay enough, and learn the skills to kind of stick with it. And then the mom saying, hold love in your heart. Love can hurt. Respond consistently, build trust, find pleasure in small moments. There's a need for connection and exploration. I love when moms start using those terms and it makes sense to them. What is connection? What is exploration? Well, we have recently, like as of 1.5 years ago, gotten an NIDA grant to actually also look at feasibility effectiveness in mothers with OUD diagnoses, and collect metrics, as you can see here, including brain imaging, fMRI, and EEG data. And it's a small pilot. It's the first phase of this R6133. Hopefully there will be a continuation, given all the uncertainty right now. The program officer is like ghosting us. So we'll see where this goes. But the data so far, we have 15 moms who completed the intervention. And when you look at what we assessed, it's going all in the right direction. I know it's a small number, but depression goes down, PTSD goes down, parenting stress goes down, craving goes down. That is really reassuring. And we have the same data on brain imaging, empathy circuit activation as we had with non-OUD moms in our previous work that I was telling you. So that's reassuring. We also have, we collected event-related potentials. I don't want to go into detail what that means, but it's basically you probe, again, this time the probe is photos of unknown children with different affective stances, and then you look in the EEG wave, the responses. And there's a immediate response, this immediate wave, and 170, and then the late positive potential. And we think that it indicates different aspects. One is the acute kind of automatic response of reacting to the stimulus, and the late LPP is more indicative of higher order processing. And it's very reassuring to see that the LPP to positive, again, to the laugh, so the kind of responding to positive visualization of an infant, the more of that activity is correlated with less depression, lower EPDS post, so post -3. The more negative means that you have less depressed after, and it's also with craving. Again, what's the chicken and the egg? It could be if you're less depressed and less craving, you can be more responsive, or is it because you're more responsive to the positivity, you're also having more reward? We know that craving for drugs, they're competing. Parenting and drug seeking is competing. Can we hype up that parenting joy to decrease craving? So stay tuned, more to come. I want to end, if I have 3 minutes, on something that I really feel strongly about, because so far I have told you, oh yeah, we are doing all this great stuff, behavioral stuff in these contexts. But the bottom line is, how can we take the nuggets of all this great work and embed it in every encounter between a provider and a patient? Every encounter. Because that's how you multiply, that's how you disseminate. So how to bring this into, and I feel strongly that it's possible. We have to shift the provider stance. Whatever you are, whoever you are, a pediatrician, a gynecologist, obstetrician, family doctor, doula, nurse practitioner, midwife, ask yourself always in that moment, how do I promote serve and return between the parent and the baby? Right? How can I promote that they have this back and forth, and that promotes relational health? And so I, as a provider, need to ask myself always, how can I learn to support you, the parent, to be an accurate observer of what's happening with your child and with yourself? What am I doing? How am I doing it? Without judgment and self-criticism, right? Often that's in the way. I was like, oh, I'm so bad. I'm doing this bad. Stay focused and just observe. And then build appreciation for what's going on with the baby, what's going on with me. And then have an appreciation to this reflection of how parenting behaviors and attitudes, where they are coming from, and how successful they are. How can you as a provider help the parent to kind of, even in a brief encounter, to do this? And I think to train the provider to themselves first observe the serve, right? There's always something happening between, let's say it's a well baby visit. I can, as a provider, see what's the overarching affect. Are they engaged with each other? Are they enjoying each other? Are they responsive? How is the pacing? How are they attending to each other? Is the mom attending? Is the baby looking away? Mutual initiation, imitation. So learn to observe so that you are observing. And now, how do you return this observe to the patient, to the parent? So you can voice it. You can say, wow, I see how you are looking at the rattle together. You are connected in this joy playing with this rattle. You are hyping up in this moment mutual attention. And the parent is like, oh, well, yeah, I'm doing it. Or, mom, you let her turn the page on her own. You gave her some agency. Wow. So a mom who might have a tendency to be intrusive and step in, to amplify the things that you feel like, oh, this is beautiful. Let me amplify that. Or, initiation, imitation. As a provider, my stance has to be for the parent to feel safe, seen, valued, understood, not feel judged. I lead with strength-based, but I also do not diminish that there are challenges. So I'm not sugarcoating, because parents notice that. If you sugarcoat, it doesn't sound real. And you join the parent in mutual wondering stance, and the hope that with persistence, they can figure it out together in the relationship. That's creating that safe, reflective stance. So we have some examples of probing questions that we can throw out. And you have many, many more. And if you can do a video review, then it's even easier. Otherwise, you have to do it in real time, right? You observe, and then you maybe throw something back. It's easier if you videotape it and watch with the parent, then you can reference it. It's much more powerful to see it. But, just asking is couple questions. What did you notice? Was this typical? What did you feel? What do you think your baby felt? What is there anything that surprised you, concerned you? What was the sweetest moment? These are easy things to ask in every encounter, and it goes far, because that creates kind of that reflective capacity. It introduces like, oh, babies have intention, feelings. There is something that driving their behavior. Broadening the frame. I suggest always that when you look at these questions, that you always, I know everybody's busy, like, oh, I can't do this. You can do this. It takes like 3 minutes. 1 or 2 questions, 3 questions. Ideally, you have one strength question where you highlight something that was a strength in the interaction. Then you go to something that was a challenge, so that you address there was a challenge. I'm not sugarcoating, but you end on "you are so beautiful" moment. You bookmark it at the end with something where you can make the parent understand you are it for this baby. And the parents walks out on a elated note. That's what encounters should be like with us physicians, social workers, psychologists, nurses, doulas, whoever. How can I do this myself as a provider? Well, I need to check myself. So I am in a regulated state. So I talk with my providers or with my trainees, use this acronym. Breathe, empathize, set yourself a goal in the interaction. What do I want to convey? Inquire, be curious about the parent and what they're doing, and engage in a way so that the parent can be the one moving forward with this interaction. Don't be the better parent, because you are not there 24/7. It's for the parent. And that means we have to check our countertransference, our values and such. So my summary, perinatal infant mental health attends to all of it: parent, child, relationship. And it's a necessary extension of standard perinatal care. Early relational well-being is crucial for child's lifelong health and development of security across the life. Meet the parent where the parent is. Office, video, community, home, residential, whatever you do, do it. And then use every encounter to make the parent feel safe, valued, understood, and supported in their reflective stance. And with that, I want to end. This is our webpage. If you are interested in it, please check us out. We have trainings and such. We have also videos that you can download. So all these concepts, we have like cartoonized videos that are easy accessible for the parents, so it's understandable. It's not psychobabble. It's good language that is understandable. It's English. I, as a foreigner, appreciate that. It's not my first language. And with that, I want to say thank you. I couldn't resist. I just came back from Bhutan, trekking in Bhutan and seeing the Himalaya. This is Mount Everest on the right side. Phenomenal. Can only recommend. So thank you very much.
No, you're perfect. I just want to say thank you. I think we do have a couple minutes for questions. We do have awards. We also recognize we have some residents and faculties that need to move on to service. There are takeaway lunches, but for those that you're staying, there's more of a spread. So, you know, we're going to continue the party for a little while. Are there any questions online or in the audience?
Just give me a moment to bring the mic around to you.
Oh, thank you, Andre.
I'm also available to answer over email. I'm very accessible. I assume you will have access to the slides.
We would love access to your slides.
Hi, Dr. Music. Thanks so much for your talk. My name's Christian, I'm one of the third-year residents. I'm curious for Zero to Thrive, how do most parents find their way to you or find out about you that may or may not know that infant mental health is even a thing? Like, is it through primary care offices or child psychiatry or?
So, yes, we are sitting in psychiatry, but granted, nobody comes to psychiatry. Nobody wants to go to. And we are only one of those ones, so I tell you, I have a lot of it. But primary care, so at some point, 94% of women get delivered in a go to prenatal care and deliver in a hospital. So we are safe, we are in pediatric office, we are in family medicine. But we work with doulas in the community. We work with community health workers. We work with lactation consultants. I am at community events, baby showers, in the church. I work with a reverend. You have to be out to psychiatry for parents. We have to be where the parents are, not that the parents come. So, and our flyers are now, I mean, I put them up as slogans, wherever. Because the point is, the access program, the point is that they just have an easy access and then come to us, and then we'll figure it out together. And
I know you had mentioned a little bit of like the frat thing for the fathers, but in general, are there ways that you've tried to engage fathers, or are there techniques that you use, given that it's pretty maternally centric programs?
it's a great, so I'm totally into the father, we initially, everything is about moms. And I am guilty as well, 20 some years. And at some point, the parents bring their parenting partner for the girl, and sometimes it was the father, and then they said, hey, what about us? And we said, what about, so we try to just replicate and do mom power for dads. Dad power. The dads hated it. First of all, they hated the name. Second of all, they were bored to death. They were like sitting there looking at the videos. The moms are like chatty, chatty, chatty. The dads didn't like it. So we realized this is not going to work. And so that's where, with the fathers, feedback rounds, feedback rounds where we're all standing in a thing and throwing the football, and you have to answer when the football comes to you. Then they would answer, because otherwise when I said, hey, any feedback? Totally silence. Okay, let's play a game. Throw the football. When you get the football, you answer. So now we paired it with adventure therapy. Adventure therapy is a modality where it comes from actually youth work, troubled youth. We're not going on a ship or do rock climbing, but we are playing games, physically active games that elicit conflict, that are difficult, that are stirring up emotionality, communication, and then translate the experience to parenting. I'll give you an example. 6 dads, you are in the group. We have a tarp on the floor, and we give you the exercises. You all stand on the tarp. You have the first 45 seconds, make a strategy, talk it out amongst each other, and then afterwards it's silence. And please, while you're standing on the tarp, flip the tarp around, which means you have to kind of go to the side, you have to flip, then you walk over. You have to work together as a group. That is it's not easy. It's really complicated to flip a tarp while you're standing on it. But that elicits initial problem solving. Did we do it right? Then, emotions like, oh my gosh, anger, frustration, I told you so, communication. And then we debrief. After each round, we debrief, and then we say, how does this show up at home? How does this show up with your kiddo? Is there something that resonates to you? And they are like, wow, yeah. So that's the way, so the same idea, the same concepts around parenting, self-awareness, but with a lot of activities to elicit access to own emotionality. Men has traditionally less access immediately to their emotionality and processing it. And yet, once they get started, I tell you, men have a lot to say and they enjoy it. And I am just blown away. And then we do the same thing like in Mom Power. We connected in week 6 to own childhood experience, being erased by their fathers, father relationships. There is so much trauma that men experience that is under the cover. So currently we are running it in Black churches, and we are right now adapting it to Morehouse University and other historically Black colleges for students. Thank you.
Thanks, everybody. Oh, I think we have to transition, but okay.
Take my mic.
So this is Megan online. She says, thank you for a wonderful presentation in regards to your perinatal access program. What level of degree or trainings do the perinatal and infant mental health consultants hold?
What's the question?
It's what level of degree or training do the perinatal and infant mental health consultants?
Yeah, thank you. On my team, there are master's level social workers. The lead, I have 7 people, and the lead is actually a psychologist. I think for a mental health intervention, you have to have a mental health degree. So master's level social work. Thank you. Thank you again. Thank you so much for having me.
All right, we're going to transition to our award ceremony. And so if you can hold on for one more minute, we're going to just honor Alma Trockley, who was the co-founder along with Carol Norshortle with Dr.